Hi, everybody. I'm Dr. Frank Phillips, a spine surgeon at Midwest Orthopedics at Rush in Chicago. I'd like to welcome everybody and thank you for joining us for this case debate series hosted by NuVasive. In these debates, you'll get to hear your peers go head-to-head, sharing the philosophies of procedural approaches and how they choose to apply the technology being discussed. With that, I'd like to kick off the next debate in our series. This is about interbody fusion devices, selection of materials and technologies in cervical and lumbar fusion. And we have Dr. Jay Turner and Mark Wang participating in this debate. By way of introduction, Dr. Jay Turner is a neurosurgeon at Barrow Neurological Institute in Arizona, and Dr. Mark Wang is an orthopedic surgeon at the Spine Institute of Arizona. So we have two experts in the space. Once Jay and Mark share their perspectives, I'll provide some closing comments to bring this debate to a close. So without any further ado, and looking forward to hearing what you both have to say, I'll turn this over to Jay to lead us off.
Okay, thank you, Dr. Phillips, for the introduction, and thanks to NuVasive for the invitation. I'm Jay Turner. I'm a neurosurgeon at Barrow in Phoenix. So the topic of interbody materials and surf technology is actually a lot of interest to me, so I'm very happy to participate in this debate. I was asked to take the position in favor of Porous PEEK and wanted to start with a case presentation. This patient was a 64-year-old female who presented with progressive neck pain and signs and symptoms of myelopathy. Imaging revealed multi-level stenosis with cord compression and associated kyphosis, which were both likely contributing to her myelopathy. We decided on a C3 to 7 ACDF for decompression of the cord and restoration of lordosis. And we know that a 4-level anterior fusion in an older patient with osteopenia is a challenging environment for fusion, and the question here is, what is the optimal interbody for the best outcome? And as we all know, there's a plethora of interbody choices today. The market is now dominated by synthetic cages for a variety of reasons, and the two most commonly used materials are PEEK and titanium, and you can find advocates for both sides. Those in favor of PEEK point to the favorable imaging characteristics and a Young's modulus that closely matches that of bone, and those in favor of titanium invariably focus on the biology, discussing how titanium interacts much more favorably with bone and is a better material for fusion. And naturally, when fusion is one of the primary goals of the surgery, the biology is critically important. But if you look at the literature where those arguments on biology are derived, nearly all of them compare porous titanium with smooth PEEK. And while some conclude that from these studies that this means that titanium performs better than PEEK, suggesting it's all about the material, they are missing that these studies are really comparing two different surfaces, and that factor seems to matter a lot in this situation. It's well established that smooth PEEK integrates very poorly with bone. We know that the fibrous capsule forms around it, and it's known to have a poor participation in bone healing. But we also know that smooth titanium has the exact same problem. And this was a study looking at the bony response to a variety of titanium surfaces in an intramedullary rod model in rabbits. And as you can see, smooth titanium had poor integration with bone compared to textured titanium. Interestingly, very similar appearing graph as the paper on the previous slide comparing porous titanium to smooth PEEK. So, smooth titanium is just as much of a problem as smooth PEEK, and this suggests it really has more to do with the surface than the material. And this comparison of titanium and PEEK, for a lot of these studies, really is kind of comparing apples and oranges. So porous PEEK is a lot newer to the market than the porous metals, but there's been quite a bit of animal work demonstrating that bone incorporates much more readily in porous PEEK than smooth PEEK. And similar to what we see with titanium, this porosity leads to significantly improved shear strength. And these concepts about surface topography and architecture are really not new. This is they've been really well established in fields like dentistry for decades. You can see papers here dating back to the early 90s. They're just now, over the past few years, becoming more mainstream in spine, but the concepts are very well established. So when dealing with these modern porous PEEK implants, it does not appear that we are compromising on osseointegration like we had been with the smooth PEEK options previously. And the interaction with bone now appears to be much more favorable. And when you consider that improvement with the existing benefits of PEEK on imaging and stiffness, it really makes Porous PEEK an ideal interbody implant. So to return to the case, that's exactly what I selected. I chose Cohere Porous PEEK interbodies at each level and a 4-level plate to help correct her kyphosis and stabilize, and she did very well. I started using Porous PEEK just over a year ago, so I'm now starting to see 1-year follow-ups from those patients, and this is one of those earlier cases, and I've been very happy with the results here. You can see a good example of that with good interbody fusion at all 4 of those levels.
Hi, my name is Mark Wang. I'm an orthopedic spine surgeon at the Spine Institute of Arizona, and I'd like to extend a thank you to Drs. Turner and Dr. Phillips, as well as NuVasive, for giving me this opportunity to present my case for porous titanium as a preferable substrate for spinal arthrodesis. Dr. Turner has done an excellent job providing a short basic science primer on the comparison between PEEK versus titanium for arthrodesis in the cervical spine, and I will present a case regarding spinal listhesis in the lumbar spine and my decision-making process. So in this case, this is a 77-year-old female with a history of chronic low back pain and bilateral leg pain with difficulty with ambulation and need for an assist device. She has symptomatic neurogenic claudication and has typical comorbidities of her age group, including diabetes, hypertension, as well as osteopenia. The X-rays shown here, including the AP lateral flexion extension views, clearly demonstrate a spinal listhesis at the L4-5 level with some translation in flexion and extension. The pre-op spinal parameters, however, indicate that she is fairly well balanced and that her pelvic tilt is within the acceptable range, and the lumbar lordosis and pelvic incidence mismatch is clearly within 10 degrees. And so as we move on to the preoperative MRI, what we've identified here is a obvious degenerative spinal listhesis, significant spinal stenosis both centrally as well as in the lateral recess, as well as significant facet arthropathy. And so in this case, there are a lot of considerations, not only just the type of interbody implant material, it's what kind of surgery can be performed. Certainly anterior, lateral, as well as posterior surgical options are available here. In my hands and in my practice, performing lateral surgery is my preferred surgical approach. But we also have to consider the bone density. We have to consider that this is a 77-year-old patient, and traditional solid titanium implants or certain other types of implants of different metallic materials may be too rigid, and they may have poor modulus mismatch. Also, we have to consider biologic considerations. Are we going to try to overcome some of her medical comorbidities with certain additive biologics, or are we going to consider our implant of choice to be part of the biologic solution? And then again, we have to consider the degree of instability. In this patient, there is some degree of listhesis, and if we're going to place an implant laterally and then perform a secondary reduction posteriorly, how do we prevent that implant from potential migration? Again, we'll have to consider the ligamentous competence of both the ALL, PLL, interspinous ligament, as well as the facet capsule when we're determining how much potential indirect decompression that we can achieve with our interbodies. And then finally, again, the medical comorbidities of surgery come into play in terms of how invasive an operation we want to perform. The intraoperative imaging, which we have at our facility, including the Lessray, allows us to do live fluoro and allows us to gauge the correction of our surgical arthrodesis in real time. That allows us to do certain things in terms of just allowing us to identify the correct size of implants, the amount of translation that we've improved, and the need for further correction from a posterior aspect. Follow-up imaging here has shown that the AP and lateral reconstruction from the XLIF approach has allowed for near complete reduction of the previously seen spondylolisthesis, reconstruction of the disc space height, and in this instance, we've added a lateral plate for added fixation, partially because of the secondary translation that I'm planning to perform with the pedicle screws posteriorly. The final construct is one in which I've placed percutaneous pedicle screw fixation and then performed a reduction maneuver, and that allows the spondylolisthesis to be completely reduced and allow us to have the largest implant we can have available occupy the interbody space. The post-op standing films, again, re-demonstrate the maintenance of the reduction as well as the placement of the hardware. Again, bringing this back to the topics of debate, I'm trying to make a case for porous titanium as my preferred option. Prior to porous titanium, certainly PEEK was the interbody material of choice, and for many, many years I used the PEEK lateral implant from NuVasive to great success. However, Dr. Turner has made some excellent points regarding imaging, stiffness, and biology, and all of which he's pointed out that in certain instances, titanium has poor imaging. It might be too stiff in certain situations, and although the biology might be good, there has to be a certain type of porous architecture to the titanium or the PEEK to make it a viable surface for fusion. So in this instance, the 3D porous titanium with a central aperture, I think, allows for excellent visualization of fusion. In this instance, a CT can allow you to see directly through the middle of the interbody implant, and really, at this instance, this is still our gold standard for fusion. Flexion extension views, while they do a good job, oftentimes there's posterior screws in place, and it's hard to see if there's really any true motion within the implant. Barring actual direct visualization of the fusion mass during a revision operation, a CT scan remains our gold standard. So I think in this instance, this type of porous titanium implant with a central aperture still is a very viable option in terms of radiographic visualization of fusion. Next, stiffness. This is definitely a specific topic of debate. Solid titanium implants, I would agree, have a poor modulus for fusion. They're too stiff, they can subside, they can essentially overcome the strength of the cortical bone in certain patients who have less bone density and cause an initial stable fusion to fail. However, the ability to 3D print porous titanium allows you to create implants with variable metal mass. This allows you to accommodate different bony environments. And specifically, this modulus implant has been designed to match more of a cancellous and cortical bone architecture as opposed to something that is more like solid titanium alloy as seen in the modulus graft on the right. So in this setting, we now have the ability to include specifically tailored implants to our patients. While that doesn't currently exist, I think that that's certainly a direction that companies such as NuVasive that are at the forefront of developing these implants can really explore, and I'm excited about the future for that. And then finally, the biology. I don't think that there's any material science specialist out there that will debate the idea that titanium is the preferred substrate in terms of bony attachment and bony healing. PEEK, we know, is hydrophobic. It doesn't like the connection between osteoblasts, and it's very difficult for certain bony elements to create a firm bond to them. In this instance, when you have porous titanium, you have early bony ingrowth, which essentially creates this early stability. And in ovine models, this is as early as 4 weeks. And then finally, when you get out to 12 weeks, you can see significant through growth. And so really an implant that combines porous end plates, a open porous structure that allows bone to then continue to grow through the implant, I think is really the ideal substrate for me for arthrodesis. In the case of Porous PEEK, while I do believe that that allows for that early new on-growth, it really then has to still complete a through-growth process through smooth PEEK, which again has the potential for fibrous union. So in my mind, while I still believe that PEEK is really currently the dominant material for fusion, I think that 3D printed titanium, specifically 3D porous printed titanium with open architecture, really will surpass that in terms of the degree of fusion opportunities that we'll have and see in our spine patients.
Dr. Wang, would you like to respond to Dr. Turner's use of Porous PEEK in his cervical case?
I think Jay, obviously as an MD PhD has done an excellent job, again, sort of describing the material science aspect of PEEK versus titanium. In brief discussions with Jay previously as colleagues in Phoenix, I've even stated that I think that Porous PEEK is an excellent substrate for cervical fusion. The area is much smaller, and it's really hard to probably create a 3D porous implant of titanium for the cervical spine that doesn't have a lot of metallic issues, given how small and how dense that area has to be. Now, I know that you guys do have a cervical modulus, but in the same instance, if I were hard-pressed, I would probably choose Porous PEEK for my cervical spinal arthrodesis. I don't think any of us who practice, spine surgery on a routine basis would debate the merits of either material in terms of our patient population.
Yeah, that was a great presentation, Mark, and I think you very well put together all the merits of porous titanium, particularly 3D printed modulus, and in reality, these newer titanium implants really do have both favorable imaging characteristics and stiffness. I've been impressed with, you mentioned and showed a nice picture of the imaging quality with bony growth through a CT, and I think it's also equally impressive the minimal amount of scatter you get on postoperative MRIs, where you can still see the canal and nerves with good detail, since there really is much less metal causing artifact. So I think the merits are certainly are very valid, and similar to your practice, modulus has become my go-to for the lumbar spine as well. I had a little trepidation with moving from PEEK to titanium for fears of increased stiffness, despite the effective stiffness by having a porous architecture. Still worried about issues with subsidence. I have many elderly patients, and worried about how that was going to present clinically. And I've been pleasantly surprised with my results. It really just has not been an issue with subsidence, despite the change in material in patients often who don't have very good bone quality. And the other interesting feature with particularly with modulus is the insertional force. Really is there's quite a bit more insertional friction due to that texture, and that raised some concern for me as well when I first started using it compared to PEEK, which slides in much easier. But it seems that the modulus almost acts as a rasp, roughing the end plates as you bring it in, and does not seem to really compromise the end plates as I feared that it may. So I agree with you. I think there's really a role for both titanium and PEEK in both environments, cervical and lumbar. And I think what's nice about this portfolio is really can cater to people's different preferences, who feel adamant one way or the other about one material or the other.
Yeah, I think I think you put that very well. I really think that the reality of the situation is that we're debating about products that are innovations in the material science space, and both are improvements on the traditional implant. We're not putting in just solid PEEK with no surface technology, and we're not putting in just solid blocks of titanium with some very sort of broad surface architecture. I think both of us have decided to use implants for very specific reasons based on basic science research, and I think the movement towards better implants, better designs, and better technology is something that a lot of surgeons want to move to, and just sometimes it's a leap of faith. But I think specifically NuVasive has done a really good job at acquiring or developing this type of material science technology advancement, and it's really nice to be able to choose specific tailored implants to your patients. If you really feel that in certain instances that a Porous PEEK implant is going to do better, I'm not fearing that is not going to achieve the same arthrodesis that a porous titanium implant would. It just becomes a matter of discretion as opposed to choosing one because basic science tells me to. I think there's enough basic science on both ends to really validate these implants as very, very good options for our patients.
I absolutely agree, and I think since they're both newer technologies, the clinical science is lagging a bit, and we do have to rely more on the basic science. But in coming years, I think we'll hopefully see some good comparative studies where we can really understand the value of these two different types of implants in different scenarios, and I predict they both will fare well. But it'd be interesting to see. In a higher quality clinical study, comparative study, how they, what the advantages and disadvantages of each are. Just a question for Dr. Wang. So most have moved over to synthetic cages. There's still some who have hung on to structural allograft. Is there any role for structural allograft in your practice, or have you moved over to titanium and PEEK for your practice?
The only time I really used structural allograft was for anterior cervical decompression fusion ACDF spacers. But my problem with them was mostly that they didn't have variable sizes or variable lordoses. And so it was always that smaller 14 millimeter cage with very little lordosis. It was all cortical or potentially maybe a combined cortical cancellous sort of machined allograft. But again, it never had the sort of variability in size sometimes that I wanted. And when we're looking more at restoring sagittal balance, as you've done very nicely in your ACDF case there, you've chosen cages that have quite a significant amount of lordosis to really reconstruct the cervical spine. And I really don't think that allograft spacers, unless they've been machined specifically to have a hyperlordotic design, really fit the bill. And so it's the custom of having the variety of implants that PEEK and titanium offer that draws me to using more of a synthetic cage in this instance. I'm not sure how you feel about that either.
Yeah, I agree. Yeah, I think those are all good points. And I would add that I think you could make a good argument for sticking with structural allograft compared to smooth PEEK. There were studies suggesting that structural allograft had higher fusion rates. But with this newer surface technology, I think we're going to see that that's going to flip the script on it, and I think we're going to see these implants that have the surface technology that are participating in the fusion, not just holding graft in place. They're actually involved in the arthrodesis that we're going to see that these have a lot of favorable characteristics for fusion. So for my practice, it's the same thing. The options for alignment and my belief that they're better for arthrodesis, which I think the jury's still out on. We need the data to show that, but my belief is based primarily on the basic science is that it's a better implant for successful fusion.
I agree. I think the idea, sorry to cut you off, the ability for the interbody cage itself to play a role as a, almost like a biologic is really, something that I think a lot of us have been looking for, as opposed to just a static inert spacing device that then would allow the fusion to sort of jump across a distance. We're now using implants that really play an active role in helping us get our fusions, and I think we're doing more and more challenging patients as time goes on, and patients have more comorbidities, and certainly as we get better at our techniques, we're trying to do more challenging things in reconstructing cervical spinal malalignments, where every area really needs to fuse. And so I do agree with you that though I think there needs to be better clinical science to validate this, I do think that these newer implants are playing more of a role in our fusion than the older style implants were.
Dr. Turner, any thoughts on Dr. Wang's lumbar case using a porous titanium implant with an integrated lateral plate?
Yeah, I agree. And the other benefit of the surface technology, you alluded to it in your presentation, is you don't, with the synthetic cages that are just holding graft, you're relying on bridging from end plate to end plate, but with surface technology, you're likely getting biomechanical advantage just by growth a millimeter or two into this porous architecture, which likely facilitates faster arthrodesis, but also gives you earlier mechanical stability. And so I think there's reason to believe, and I think we'll likely see results that continue to roll out to support that they perform more favorably than the older implants.
Thank you, Dr. Turner. That was an excellent presentation, and I appreciate all the thoughtful points. At this point, I'd like to turn over to Dr. Frank Phillips as the moderator to give his thoughts on both sides of the coin.
Thank you both for a very thought-provoking and interesting discussion about an area that's very topical at the moment in spine surgery. There's been a lot of promotion, marketing, science about materials for interbody fusion in spine over the last 5 to 7 years. I think this debate very nicely captures some of the highlights of the various materials and the science behind these materials, and also the clinical application of both of these materials discussed in the debate today. This is an area of fairly intense interest of mine. One of the things I'd like to point out as we move this forward, I think it's very important to separate out materials and surface architecture. So as has been discussed, smooth PEEK is not very friendly. I would argue the same is true for smooth titanium. So I think it does us a disservice to say PEEK is bad and metal is good. I think as you guys have nicely discussed and debated, it's about the surface material. And there's very good preclinical and emerging clinical science about the efficacy of both of these materials and how we can apply them to our practices. Clearly, there's advantages and disadvantages of both. The advantage of Porous PEEK obviously revolves around our ability to accurately assess fusion on X-rays. This is obviously more challenging with metallic implants. Others have argued porous or micro-architectured or nano-metallic implants are good for growing bone. So I think as this field evolves, we need to understand all the options, evolve with the field, and ultimately make evidence-based choices that we think are in our patients' best interest. So thank you very much for a thought-provoking and interesting discussion.